Over to you.
Tēnā koutou katoa. He karakia whakatikira tā tātou hui I tēnei wā o te tina. Whakataka te hau ki te uru, whakataka te hau ki te tona, kia mā kina kina ki uta, kia mā taratara ki tai. E hi ake ana te atakura, he tio, he huka, he hauhu, tihe, mauri ora. Mauri ora kia koutou nau mai, hara mai. Ki ngā mauna teitei, ngā awa tapu, ngā reo kōrero, ngā manukura, ngā māreikura o te waka hauora o te motu whānui. Piki mai, kake mai. He mihi tēnei kia koutou o te huna, o whakarauika mai ki tēnei hui. Kairunga tēnei momo ahurewa, he mihi whānui, he mihi mahana mai te whānau o te Hiringa Mahara. I runga tērā e karema, tēnā koutou, tēnā koutou, tēnā tātou katoa. Kai a koe Sonya.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko te mihi tuatahi ki a koe e Maraea, mō tō karakia atahua me tō mihi ki a tātou I tēnei wā. Tēnā tātou, ko wai ahau, no Croatia me ngā pui o Kutupuna, ko Sonya Russell toko ingoa. Ko au te Kaiwhakahaere, Hauora, Hinengaro, Waranga o te Hiringa Mahara. Ngā mihi nui, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora everyone, I'm Sonya Russell, the Director of Mental Health and Addiction Sector Leadership here at Te Hiringa Mahara, the Mental Health and Wellbeing Commission. And it's my pleasure to welcome you today to this webinar on the Access and Choice Primary Mental Health Programme. We will be going over our recently published monitoring report on progress and achievements at 5 years and sharing our key findings and recommendations. We will be recording this webinar and it will be available for those of you who have registered. We will send you a link after the webinar. I will start off by telling you a little bit about Te Hiringa Mahara and our previous reports, and then I'll hand over to Kerri Kruse, our Senior Policy Advisor, who is the project lead for this report, and she'll present an overview of the report. Following Kerri's presentation, we will then hand over to our fabulous panel, who will share their experiences with Access and Choice. Our panel members bring different perspectives. Genevieve Obbeek is a health improvement practitioner from WellSouth Primary Health Network, and she brings a workforce perspective. Leilani Maraku, who's the Manukura of Mana o te Tangata Trust and brings lived experience. And Carole Koha, who's the kaihautu to te Waka Whaiora Porirua and te Menenga pai Newtown, and she brings a Kaupapa Māori service perspective. Following our panel presentations, we'll then have time for you to ask some questions at the end. And if you could please use the Q&A function to ask questions, that's at the bottom of your screen. We'll be monitoring this and putting these through to our panel. Please also add a thumbs up if you're interested in a question that someone else has asked, so that we can prioritise, as we may not have time to answer all of the questions. We're hosting this webinar to share our findings and hear from different perspectives. So please be respectful and kind as we do our best to answer your questions. Kia ora. So I'll go to our first slide and give you a bit of an overview of Te Hiringa Mahara. So we are a kaitiaki of mental health and wellbeing, leading improved mental health and wellbeing outcomes towards all people in Aotearoa, New Zealand, thriving together. We're an independent Crown entity and we're committed to being grounded in Te Tiriti o Waitangi. Our key functions are system-level oversight and leadership, monitoring, reporting and advocacy, and through our monitoring work, we shine a light on the things that are working well as the things not going so well to drive improvement of the overall system. We go to the next slide. Many of you will be familiar with Waranga, which was the inquiry report into mental health and addiction. So through this report, it identified a known gap in services for those to mild to moderate mental health and addiction needs. And 12 of the 38 recommendations in that report talk to increasing access and choice for services. That was followed by Budget 19, in which there was a substantial investment into primary mental health services. 644 million was allocated over a 5-year period from the wellbeing budget, and 20% of that overall funding was dedicated to Kaupapa Māori services. The way these services were commissioned was quite unique, taking a Te Ao Māori approach to the commissioning of those services. And a key point of difference is that, and you'll hear more about that from our panellists in terms of the difference that made for Kaupapa Māori service development. We've been monitoring this program since the beginning. So we've published a report in 2021, which covered the first 2 years. And we found in that report that the program was largely on track. The integrated primary mental health services were ahead of schedule, but some other services were behind schedule, particularly Kaupapa Māori, Pacific and youth. By the time we published our second report, we'd seen a huge growth in Kaupapa Māori services. There was a bit more work that was needing to be done in terms of the rollout of Pacific services, and we found that the rollout of the youth services was progressing well. This report that we're going to be talking to you today about is our final report at the end of the 5-year rollout time period. And we set out to provide an independent assessment of the public investment into this program for the purposes of public accountability and to inform ongoing decisions about the future of this program. On that note, I will hand over to Kerri Kruse, who will take you through the report. Kia ora.
Kia ora, Sonya. Tēnā koutou katoa. No te mana me airani o ku tupuna, I tipu ake au ki New Jersey, ko lanai lenape te iwi take take o te rohe. I tai mai au ki Aotearoa I te tau 2000, e noho ana o ke te whanganui atara. Ko Kruse toku whānau, ko Kerri taku inua. No reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thanks everyone for being here with us during your lunchtime, and I'm really happy to just talk you briefly through our key findings and recommendations for the report. Access and Choice program provides free, accessible support to people with mild to moderate mental health and addiction needs. It had a 5-year rollout period from the 2019-2020 financial year to 2023-24. So our report covers this rollout period and thus only includes data up to the 30th of June 2024. But the goal of the program is to provide support to 325,000 people per year, which is approximately 6.5% of the population. It comprises 4 types of services, the first being integrated primary mental health and addiction, or IPMHA services, which are provided in general practices and are available to everyone enrolled in those practices. IPMHA includes a few different roles, including health improvement practitioners, or HIPs, health coaches, and support workers. Kaupapa Māori services are whānau-centered services delivered by Māori for Māori. Pacific-led services reflect Pacific culture, languages, values, and models of care, and youth services are delivered in settings that are acceptable and accessible to young people. Next slide, please. So the monitoring report seeks to overview 2 overarching questions. What was delivered by the Access and Program, and how does this compare with its intended rollout? And how has the program contributed to changing the mental health and addiction service landscape? And so to answer these 2 questions, we used a range of sources of information, including quantitative data received from the Ministry of Health and Health NZ, as well as some qualitative engagements that we conducted with a number of Kaupapa Māori, Pacific, and youth providers. Next slide, please. In terms of the aim of reaching 325,000 people per year, by the last year of the rollout, over 207,000 people were seen. So this represents about 64% of the goal being met. There are a number of likely reasons for the reach aim not being met, including COVID lockdowns and workforce recruitment challenges during the early years of the rollout. And next slide. So we looked at the reach achieved each year of the rollout, and we applied a linear trend projection to estimate when the 325,000 aim would likely be met. And it appears that this could happen around the end of 2026 or shortly thereafter. Next slide, please. The Access and Choice program has been successful in reaching a broad range of people. Across all of the 4 Access and Choice services combined, about a quarter of everyone accessing services was Māori, which equates to over 55,000 Māori seen in Access and Choice in the last year of the rollout. About 11% of the people seen were of Pacific ethnicity, 9% were Asian, and 20% were young people aged 12 to 24 years. It's also important to note that Kaupapa Māori and Pacific Services are seeing about a quarter of their clients who are non-Pacific or non-Māori, so it's reaching a broad range of people. And in our report, we stated that we would like to see further assessment done around the coverage for Māori Pacific youth, as well as Asian populations and those who are missing out of the program. Next slide, please. In terms of coverage, the aim of the program's rollout was to have 70% of the population enrolled with a GP to have access to IPMHA services. And this 70% goal was nearly reached with 68% coverage achieved. However, there is considerable variation in IPMHA coverage by district, ranging from 45% coverage in Auckland to 100% in Lakes and Wairarapa districts. Kaupapa Māori services were available in all 20 districts with 32 services available. Youth services were also available in every district, and Pacific services were available in 9 districts that were planned to have them based on the proportion of Pacific people in those districts. So overall, the coverage of services is pretty good, although we do note our concern in the report that some people are being left out. And another access issue we highlighted in the report was around people's ability to access HIPs and health coaches in GPs and whether or not they need to see a GP first to then be referred to a HIP or health coach, because requiring people to see a GP first introduces an access barrier around the cost of that consultation. So addressing this variation in access is something we have called for in our report, as the Access and Choice program was intended to be free. Next slide, please. Regarding the program's workforce, by the last year of the rollout, 84% of the required workforce was employed, equating to over 1,200 FTEs in place. And so recruitment and a sustainable workforce is an area that we have highlighted in the report as still requiring further attention. In terms of the productivity of these roles, we received data for a small number of IPMHA providers who have regular FTE reporting, and we found that HIPs and health coaches deliver, on average, about 6 to 7 sessions per day. And the report and the changes that we'd like to see highlight productivity as an issue requiring further attention. So for example, productivity might be able to be enhanced through extended use of virtual sessions, as well as multi-practice models. Next slide. For the investment that was made into the program, of the $664 million that was allocated to Access and Choice over its 5-year rollout period, $628 million was spent or committed, resulting in an overall underspend of $36 million. And these overspends were more pronounced in the earlier years as there were delays due to COVID, but in the last year or two of the program, the spending was on track. And it's important to just note that the underspend is not just sitting there as money available, it has been applied to subsequent years' baseline for the program. And one of the things that we called for in our report is the importance of sustaining the enabler funding stream so that services can be embedded into practices, as well as the importance of extending service contracts so that funding is more sustainable for the providers. Next slide. The 5 most common presenting issues for people accessing IPMHA services over the last 2 years in order of highest frequency were anxiety, followed by depression or low mood, generalized stress, other physical well-being issue, and diabetes. And the diabetes is relating to the fact that health coaches, and to some extent HIPs, can support people with a range of health issues, including managing chronic illnesses, which also can have mental health impacts. One of the things we called for in the report is understanding if the needs of people with substance use and gambling issues are being adequately addressed by the program, as we did hear that these issues are being covered by the program, but that people may not present with these as their main concern, and therefore sometimes these issues are less visible in the data. Next slide. This is a photo of our team with we had two reference groups, a lived experience reference group and a sector reference group, who helped us to shape the report, in particular the recommendations and the changes that we'd like to see. So big shout out to our reference groups. In our qualitative engagements with a number of access and choice providers, they helped us to understand how the program contributed to changing the mental health and addiction service landscape. So it's clear that access was increased and options were expanded for people with mild to moderate distress with a range of services from which to choose. Kaupapa Māori and Pacific services are often seeing whānau and not just an individual, so they're quite whānau-centered. And Kaupapa Māori, Pacific, and youth services are providing holistic support that looks after the whole individual and not just their mental health needs. And the cultural appropriateness of the Kaupapa Māori and Pacific services is hugely significant to people. Kaupapa Māori services offer flexible, collaborative services delivered in Te Ao Māori context with connections to whakapapa, whenua, traditional practices, and skill building. We do have some limited data on the impacts of the program on people. So for example, through a few access and choice evaluations that have been conducted by external providers, and they do point to positive impacts, such as people rating the services as being helpful to them. Many providers are collecting data on the outcomes of people accessing the program, but this is not being done consistently and it's not being reported consistently. So we have stated in our report the importance of improved reporting requirements so that we can better understand the impact of the program on people. And lastly, GP staff are overwhelmingly reporting that having access and choice staff to refer people to is relieving their workload, time pressure, and stress, and increasing capacity and capability to support people and address complex needs. Next slide. So the specific recommendations we made to Health NZ are that number one, the reach needs to be increased to hit the goal of reaching 325,000 people annually. Number two, the pathway from access and choice youth services to specialist youth services. So this is the infant, child, and adolescent mental health services, or ICAMS. That pathway between access and choice youth and ICAMS can be streamlined so that the two services work together more to support young people, such as through shared care arrangements. And then the third recommendation is around that variation we talked about regarding whether people need to see their GP first or whether they can access a HIP or health coach or support worker directly, requiring a plan to be addressed. Next slide. These are our three main outputs relating to Access and Choice 2025. On the left, our main report. In the middle, a literature scan that we conducted or commissioned on primary mental health and addiction models. And on the right, there's an infographic on Kaupapa Māori services in both Te Reo and English. Next slide. Just big thank you to everyone who contributed to this report, including our two reference groups mentioned earlier, and our two peer reviewers, the providers we engaged with, Health NZ, Ministry of Health for supplying us with data, and my colleagues who supported this mahi. But also thank you to the frontline staff who deliver these services and to the people who have used them and shared their experiences. And thank you to everyone who's making the time to listen to this webinar. And so I will go back to you, Sonya. Thank you.
Hi, Kerri. Thank you very much. So I'll hand over to our panel now. So we'll come to you first, Genevieve. Kia ora.
Kia ora koutou katoa, ko Genevieve tuku ingoa no Otipoti Ahau. I'm the program lead for Access and Choice, or the IPMHA stream for Southern. I'm not currently working as a HIP as introduced, but I did start in the program as a HIP in 2019. And have worked as one of the national HIP trainers, and we're currently leading a regionalisation of the HIP training program for Te Waipounamu. And I wanted to talk a little bit today around our workforce, but also what we might need to reach the 325,000 people intended as part of this program. But I wanted to start firstly by acknowledging our workforces. It has been, I think we're all here because we want to help a lot of people and we want to make a real difference to the lives of people in our communities. And on the surface of what we do in this program seems quite simple. We sit in general practice or in other settings and we see a lot of people, but the mechanisms behind that is a little bit more complicated. And these are people that are quite isolated in their roles. They're often the minority in a general practice environment, and they're tasked with bringing about service delivery change. And there's a lot of competing priorities in general practice. So what the Access and Choice staff across all of the streams have achieved over the last 5 years is nothing short of remarkable, really. So a big shout out to all of them, and also to the leadership that sit across these 4 streams as well. It's a new thing, it's a new model, it's a new way of doing things, and it does take time and it takes a lot of patience and perseverance to sort of embed these new ways of working into our system. However, I'm really interested in what we sort of do as a program around reaching more people. I think we all agree that's what we want to do. Coming from a perspective of Southern, I can't talk on behalf of everyone, and certainly only from the perspective of IPMHA, I think there's a few things that would really benefit us in terms of reaching that aspiration. So firstly, getting some guidance from Te Whatu Ora around what that might look like at a local level. What is the kind of population target that's relevant for our district or our region? And I think there probably also needs to be some better local advertising of these programs. We've got unique kind of communities and demographic breakdowns. There's probably a lot of trends, but we've got the rural and urban sort of differences as well, which require different approaches to build awareness and understanding of these programs in the community. But also we've got priority populations in this program too. So we want to attract Māori and Pacific, and we want to attract young people into the service. So, how do we do that and reach the right people in creative ways? But secondly, I think this workforce needs to be seen to be vital in being able to identify people that would benefit from proactive outreach and support. We are well suited sitting in a general practice environment to identify people that would benefit from engagement with this service, and being able to reach out to them and offer them something that is free and accessible, and we can work through what some of those engagement barriers might be. And the way that we kind of need to do that is probably around improvements in the training program. So delving a little bit deeper into what working under a population health approach might look like, what those initiatives could be, and how to engage with the general practice team around establishing those things. And also thinking about our unregulated workforces and equipping them well to be an important member of the general practice team as well. And something that we've adopted at Southern is the Kōrero delegations framework, and that allows us to work really closely with different services and teams to identify a particular problem or something they see as an opportunity to address, and we create evidence-based and safe clinical pathways for our health coaches to kind of contribute in that way. And I think really investing in and upskilling in these workforces, they're really, really critical, because getting registered health professionals across the sector is still difficult. So how do we invest in those workforces and really prepare them for working in a busy, chaotic clinical environment like a general practice? And I guess the final kind of point that I wanted to make was we might be 5 years in, but I do think it's going to take 10 years to fully embed this as a program that exists alongside other primary mental health and other, wellbeing programs in our sector. And, there's still lots of work to be done to make this look like an attractive career pathway for people. And, there are issues around pay parity, and there's issues around a perception that people are being kind of taken from other mental health sectors to come in and work in the Access and Choice program, and there's issues around retention. So I would really like to see that there's a national approach to building up this workforce in a way that really aligns and complements existing services, but it gives someone a really attractive option when they're looking for roles coming out of university, and that it's a really viable pathway that doesn't just end with being endorsed as a HIP at the end of 6 months. So I think, collectively we can achieve that, but we need time. We probably need a little bit more investment in terms of leadership and access and choice to be able to come together and start to explore ways to help connect all the dots, because it's all connected, and it's all sort of independently very important for the sustainability of the program moving forward. And I think that might be me, so kia ora.
Kia ora, Genevieve. Thank you very much. I'll hand over to Leilani to pick it up from here. And I see lots of questions coming through, so we'll get to those after the panel have spoken. So thank you. Over to you, Leilani.
Ngā mihi kia koutou katoa. Ko Tararoa tuku manga, ko Manawatu tuku awa, ko Kerri tuku marae, ko Ngāti Raukawa, ko Maupoko, ko Rangitane tuku iwi, ko Leilani Maraku tuku ingoa. It's a great privilege to be here today to kōrero on the perspective of Māori with lived experience, and also to speak from Mid-Central region as well. So part of our collaboration, probably a part of our success, was of collaboration with our PHO Think Hauora and our Māori and iwi providers in Mid-Central District, of coming together and looking at our collective service model. And within that approach was the ability to ensure that we were reaching our whānau. But most importantly, within that space, what we did do was the HIPs resided with Think Hauora, and our health coaches went out to our Māori and iwi providers. I think a big part of that collaboration is that we developed our own job descriptions to be able to be fit for purpose for our organisations and for our communities, but also being able to practice in our strength, which is the really important thing, and being able to build that rapport and that relationship with our communities. I think a big part of it as well was around our workforce development within this space. What we knew is, and what we needed is that to ensure that we were meeting the needs of our whānau. So needed to mihi to tihi, because for them coming on board and also supporting our way of being as a people, and ensuring that we have that good workforce development that supports the kaupapa in regards to whānau ora, rongoa, hono kōrero, all of those stuff that we as Kaupapa Māori, that's our day in, day out kaupapa. So ensuring that it was embedded throughout the program. I think the biggest part as well, and it's from observations, because we started when this first came out into the sector. Some of the observations that I wanted to kōrero about was obviously we had national training that was put out across, which was obviously a contractual obligation that we needed to uplift. But what I did see from observation is that it was supportive to our team, but some of it wasn't fit for purpose for our communities and the needs to meet our people. So for me, it would have been really good to be able to see resourcing that was put actually at a local regional level to support the community to be able to develop the training that best fits our whānau. The other part too, which I think would have been really crucial and a part of it as well is actually the education for general practices for the readiness and awareness of this workforce that was coming through to work in collaboration to support the community, which would be a really good opportunity to get the understanding, and probably adds on to Genevieve's kōrero around, you know, knowing the workforce. And obviously it's a whole new thing. It's a good space that we needed to be in and to be putting us at the front sort of line within those spaces and meeting the needs of our whānau. I suppose the other part I wanted to touch on is I wanted to mihi also as well to Hiringa Mahara, obviously for pulling this report together. And also I want to highlight as well, you know, what they have done is the best to what they were resourced to be able to do. But within part of those areas, you know, there was probably a lot more that could have been reached, and that wasn't anything to do with themselves. That's due to capacity and resources. And also it's been noted as well, there is a lot of data that is out there that hasn't been reflected through the report, and there's been real amazing mahi that's been happening across the motu in many communities. That would be great to, you know, be able to have that brought in. And then I think also the wider success and innovation of Kaupapa Māori mental health and addiction services that have come into this kaupapa of really being at that grassroots level has been an instrumental driver to engage with our whānau, making sure that they're a part of, you know, the kaupapa and the part of everything that we're doing. On that note, I want to share, you know, there is, you know, success through the kaupapa. There was more resources and capability for, you know, for the sector. The biggest one was we're able to reach whānau in need. Also been able to connect whānau that weren't aligned to any GPs to ensure that they had the support for, you know, for their hauora. And also with what this also complemented was connecting whānau to the wraparound services that are in their community. I think most importantly, my last words is most importantly the opportunity of allowing our whānau to see their true potential and not to see themselves as a deficit, but rather the solution to their journey to hauora and Māori order. Kia ora.
Kia ora, Leilani. Ngā mihi nui. That was, yeah, it's really powerful. Thank you. And Carole, I think it's over to you now, so kia ora. You're on mute.
Kei te mi kia koutou. Kei te mi kia koe e Maraea tō karaki o tēnei huihui. Ko ai au, whangatautia te maunga, karari kura te moana, te ohaki te marae, te raroa te iwi, kura haupō te waka, ko Carole Koha tuku ingoa. Kei te mahi a hau, pau kaihautu o te Menenga pai me te waka Whaiora. Hey, it's a privilege to be here and to be able to be a part of this kaupapa. Access and Choice actually provided a platform for Kaupapa Māori providers. It sure did show an increase in providers, and also it brought out a way that Māori providers could actually deliver services their way, for Māori by Māori. And that has come at a great success. That's been one of the benefits. I belong to a collaborative of services. So we joined together 5 providers. There was from Ngāti Toa's been the lead provider, also Te Waka Whaiora, Maraea Clinical, Te Paipai Arahi, and over in Wairarapa, we also had the pleasure of having Wairarapa Hauora as part of our collaborative. So we have been fortunate in being able to cover quite a wide range of service delivery and capturing a number of our Māori people within that. And one of the things that has proven to be one of the great successes is the ability to deliver programs from Te Ao Māori and being able to use our tikanga and kawa and tangata within access of those services, actually learning who they are, where are they from. So that's been one of the biggest successes in having one of the programs ko Waio. and that was a 12-week program. Also, programs that were delivered were, you know, Te Ao Māori games, Te Ao Māori pūrākau, weaving, doing all of, you know, a lot of different games and activities that were Te Ao Māori, and not just doing them in a room either, like in their office space, being able to go out to the ngahere, the awa, the moana, and being able to deliver programs in those spaces that are certainly very special to us. Having the ability to learn the tikanga and the kawa, also learning the tikanga kawa of Ngāti Toa, that was certainly a benefit to us as taurāhere residing in these spaces. What are some of the challenges? There's been quite a few challenges. One of the biggest challenges, and I want to talk a little bit about workforce as well, but one of the challenges has been around tangata who don't have GPs. And how do they access those services? We as Kaupapa Māori, we still took them. We took those those tangata, even though they weren't referred by GP, and we certainly did invite them into the programs. The difference between 3 contracts that Te Waka Whaiora does have is, one is the AOD Kaupapa Māori, which is access and choice, early intervention. One of the other ones is our Kaupapa Māori program, which is the Tuakana Taina, and that's about programs. That isn't about one-on-one, it isn't about GP services, but it's bundled in there along with access and choice. And then the other one, that one's led by Ngāti Toa. The other one is with Tuora, which when the contracts were first given all out to the PHOs. So we have the 3, and they're all different. They're different. The reporting's different. So within our PHO with Tuora, we have 7 FTEs in that program, and the reporting is basically primed. In our Tuakana Taina program, that reporting is pages and pages and jump through the hoops and over the loops and over the hills. Lots and lots of reporting are required in that. So, you know, that's a challenge in itself, especially when you hold 3 contracts that the reporting is very different. And the other challenge, like I said, is about tangata not having GPs. As we know, there's not enough GPs in the country, and majority of GP are closing their books. So that has been a real challenge for tangata. The other one is when we talk about workforce, you know, we have the HIPs, and then we have the health coaches, and then we have what they call the support workers. For me, I did not agree with having support workers. It became like a tono, like the HIPS tells the health coach what to do, the health coach then tells the support worker what to do. So I did away totally with the support worker, and we just supported the HIPS within all of our GP services. So, and that worked. That works for us. And one of my biggest things around when we talk about workforce is it's not all about qualifications. You know, you want to be a nurse, you be a nurse. But the other part of it is that the best people in these roles in terms of the health coach, like a navigator, the other people, especially for Māori, are the ones that know the community, know the whānau, they know the go-to people, they know the kaumātua, they know the marae in their regions. And they are the ones that I believe are best to go to. And it's about how do we upskill and improve their knowledge. The answer to that for me is that we need to have acknowledged that we do, or Kaitohu will do an iwi qualification, and it is endorsed by iwi. And that's my preference in terms of what are we talking about when we talk about workforce. That has been done. That has been done by Te Oranga Nui, an organisation up in Whanganui. and they did a whānau order training that was specific and precious to them, and it worked. So I would like to see us venture into something like that as well, where it is iwi endorsed. And even talking to whānau, you know, like asking them first and foremost is, what is it that you want? You know, I tautoko Lani's kōrero, and aroha mai Geneva, I hope I've said your name right, but also, you know, the other two speakers, and, you know, we're more or less saying the same thing, but just in a different way. But I really do think the opportunity and the foresight around giving Māori an opportunity to deliver access and choice in a Māori way, and using what is important to us in terms of tikanga and kaua, in terms of our pūrākau, and being able to share innate kōrero with ourselves and with the people that we provide that service to. So, hey, I don't have much more to say, and if you have any questions, fire them at Sonya. Hey, it's been great, and ngā mihi to all those that have come to listen to our stories. I'm sure, you know, there are things that we could do better, but in saying that, you know, we really need to look at all of our Māori workforce providers like Te Raora, you know, who can come in and provide services, and they're free. So, you know, we need to look around at what we do have and not just reinvent the wheel for the sake of it. So, kia ora koutou.
Kia ora. Ngā mihi nui to all our panellists, and thank you, Carole. You've got a bit of comments coming through on the chat supporting your whakaaro. So that's great. We'll get into the questions. There's been quite a few questions coming through as we've been talking. So I'll start firing those at our panel members, if that's all right. And yeah, lots of good stuff that your kōrero has generated. Some really great questions. So the first one, I think, for you, Genevieve, is about workforce training. So there was a question that came through about generic versus mental health condition specific training, and a question around a little bit about the training that's provided to access and choice staff, and specifically the question relates to obsessive compulsive disorder, recognition, support and treatment.
Well, I guess all access and choice staff through the IPMHA stream receive training through TPO, or, you know, through providers that TPO subcontract. And they vary in what they look like, but ultimately they're designed to support people to start working in a general practice environment and to work as a generalist, because for a lot of our clinical people, they do tend to come from specialist mental health environments. So what does it mean to service an entire population from the very young through to the very elderly? And our HIPs are trained in focused acceptance and commitment therapy, which is a trans-diagnostic tool, which also allows us to work with whatever might come up for that person that is most important to them, and how that kind of relates to their values and to their goals, and sort of supports that process really to identify what those next steps might look like for them in addressing their well-being. So we don't turn anyone away based on what they're presenting with or what a diagnosis might be. And we will, you know, have a conversation with people no matter the issue that sits on top. And for a lot of people, they get their immediate needs met. And for other people, you know, we work with them to signpost other services that might help address more complex mental health issues. We obviously have access to a range of e-therapy tools, and depending on what other services are available in particular communities, helping with referral pathways for people, or helping sort of explore what options might be available for them. I don't know if I answered everything there, but we certainly don't sort of associate ourselves with working in that kind of moderate to severe space, because we recognise that actually part of our role is being kind of facilitating like the right help at the right time. So we can be really effective in the mild to moderate space. We can also be very helpful in the moderate to severe space. But that's when we're going to start to look at what else does this person need to support their well-being.
Thanks, Genevieve. Just looking through our questions. There's a few questions here just in terms of quite a few around workforce and Whaiora. And I might just pass this one to you, Kerri. That's all right. So there's a question here about evaluation of impact on the wider mental health and social support workforce.
Kia ora, thanks for that. There have been a few evaluations done on access and choice services, and they tend to be service specific. So IPMHA, I think there's 1 or 2 done on Pacific services, 1 or 2 done on Kaupapa Māori, and I think 1 done on youth services. And those tend to be a little bit more process oriented in terms of in the earlier years of when the program was being rolled out. How is this being done? And was the workforce in place? Was the money being spent, et cetera? So they were quite process focused. There was 1 or 2 done, I know 1 in particular by Synergia on IPMHA, and it did contain some outcome information for the individual, but not necessarily, or I'm not recalling if there's more information on the wider mental health system. But for example, I think they compared some mental health scores, standardized scores like Waranga or the Duke score, which is a kind of a mental health assessment score, kind of before and after receiving services, and there did, show some improvement there. But I'm not recalling if that evaluation looked at the wider mental health system and impacts on that. And that's something that we touch upon in the report in terms of one thing we heard in particular with regards to youth services is that youth providers with access and choice are holding on to young people longer due to that limited access to specialist services. So that constrained specialist services, especially in the youth space, is impacting on access and choice. And so, yeah, that's probably something we have drawn attention to in the report that does require some further investigation.
Thanks, Carole. Thanks, Kerri. Carole,
yeah, go, Sonya.
I just wonder if you wanted to talk into that youth space. So that was something I think that you talked about in terms of rangatahi.
Like it is that timing, move over. We can't be saying that we're rangatahi when we're, my thing is stops at 25. When you're still talking rangatahi after you're 25, you're dreaming. And it should be, like we say, Māori for Māori, tangata for tangata, and it is rangatahi for rangatahi. We need to be encouraging more rangatahi into developing their services because they know what sort of services they want, and more rangatahi are going to be more inclined to attend it because they want to, not because they have to. And those are the things that we also need to be mindful of, is rangatahi are going to draw rangatahi. And it would be great to see that we do invest more into those services. I don't have a contract in my access and choice for rangatahi, but I actually have five rangatahi working in my rangatahi that I'm developing, because that's the future. That is the way of the future. In 5 or 10 years' time, I would probably would have to close up shop, because we're going to have Māori rangatahi coming through that's their first language. And when we talk about rangatahi coming through with the reo, and we're talking to services that don't have a lot of reo, it's going to be very hard to deliver effective services. But the other thing is, Sonya aroha mai, I did want to touch back onto the workforce. The training that came out for our health coaches, it was very, how can I say it? Well, not fit for Māori. It needed to have a lot more cultural aspect to it. Big parts of that training is good, but I see the training for the health coaches, like I said earlier, it's about knowing the communities. They do a lot of education on different diagnosis, like asthma, diabetes, and they have some really good training in that in the access and choice around that for the workforce. But, you know, I would like to see that we invest or also allow for organisations like Te Rauora, Kaupapa Māori organisations to come through and also to assist in that training, because they are all Māori facilitators who come with all that knowledge, all that mātauranga Māori, which non-Māori would benefit by too, not just Māori. So, yeah, all you want to be teenagers, move over. Kia ora.
Kia ora, Carole. Thanks for that. Look, there's quite a few questions coming through in the chat in terms of variation, and one of our recommendations that Kerri talked to before was about unwarranted variation. So I'll try and just direct some of those. So one of them was about those multi-practice models, and what do we mean by that? So I'll just attempt to answer that. So that's very much about some of the, and I think there was also a question I saw about rural and urban. So recognising that not all practices are as busy as others. So there might be opportunities for HIPs and health coaches to work between different practices, and there's potentially some productivity gains that could be made through that. Also, obviously, that does add a travel component, so we need to understand the impact of that. The other question that's come in is about Whaiora, and wondered, Genevieve, are you able to talk to that, or is that a specific Whaiora, the support worker program that was running in just the Auckland area? Are you familiar with that?
I'm not, sorry, no.
No. Okay. So Whaiora was is a particular service that's offered in the Auckland area, and it is that link through to support workers, so that there's some ability for health coaches to refer on to support workers, and they can support people for a longer period. I think, Carole, you talked about those support workers, so there is some variation across the country in terms of how support workers work in with this model. We made a recommendation about unwarranted variation, and the reason we put that word in was to be really clear that sometimes variation works, and it's important that services are able to be tailored to local needs, and we don't, there's no expectation that this model will look the same wherever it's rolled out, but recognising that in some areas there are some opportunities, I think, for the HIPs and health coaches and support workers to be used in more flexible ways that might allow greater access to those services.
Kia ora.
Kia ora. I think I've answered that about the variation. Just looking at what other questions have been coming through. Here's a question about reaching the aim of 325,000. So I might hand this one to you, Leilani, if that's all right, in terms of how do we ensure that people know more about services that are available, kaupapa and tikanga Māori services and initiatives, and how do we ensure that whānau and community have more awareness of these services? Is that something you're able to?
Yeah, I think so. I mean, for me, I'm so privileged to have been in, our area of Mid-Central, and I need to just showcase the collaboration of obviously our partnership, obviously with Hauora, but also I really need to acknowledge the Kaupapa Māori and iwi providers. I mean, we've been working together in collaboration for the betterment of our people for a very long time, so that's at the forefront. And when you have that relationship, that trust, we're not trying to squabble over whatever coming in, we're actually here for the authentic purpose of our community. That's how you get the reach, because we're actually reaching the whānau that is actually the need for the support of this of what we're trying to provide. And I think it is for collaboration and connectiveness of communities. And it's about how we put aside, you know, whatever it is and utilise our strengths to the best of that ability. So I think the best way is how we can reach that is that within all of our different rohis, that we are truly working in this context and we are truly you know, walking the talk that this is for our people. And so I think the best way that can happen is actually having a strong community, but actually looking at your community champions. You know, for a lot of this, for me, especially talking from a lived experience perspective, we have so many people in our community that are doing this mahi, and they're doing this mahi without any putia at all. So it's about how do we elevate that and acknowledge that and support that along across working in collaboration with the community. So I think the biggest part is ensuring communities are truly working collaboratively together for the betterment of their whānau, but also, you know, utilising what's in there. So we have the reach, and it's about supporting that reach, but ensuring that it's done authentically and true. So hopefully that's answered the question there, but it is about stepping up, but it's also acknowledging and supporting what's already happening in our communities, because a lot of that is already happening, and how best do we support that kaupapa as well.
Thank you, Leilani. Yeah, that's important, and yeah, to those connections into community, so important. So thank you. Look, I think we have come to time. So
Sonya, can I just add something to that? So with our tuakana contract, there's probably about 28 providers nationally, and we come together every 3 months as providers. So we get to share, you know, what's working, what's not, how can we improve access to service and all of those things. So, you know, that's another way of making sure that you keep connected, is that within your own rohe, like Lani said, is about that coming together. The only other thing before you do close is I just wanted to do a huge shout out to Nimish. You know, Nimish, you were one of the ones that first started this platform for us, and you're a great person. Kia ora.
Kia ora, Carole. Hey, look, I really just want to thank our panel members, Genevieve, Carole, and Leilani. Really thank you for your time today, and thank you to everyone who's joined online to join us for this webinar. We hope that it was useful and informative, and we do encourage, there is a website for kind of how to access these services. So we do hope that some of what we've talked about today does help to raise the awareness, and we will send out links to the presentations, and you will also have access to the recording. So on that note, I'll thank you very much, and I'll hand over to you, Maraea. Kia ora.
Kia ora, Sonya. Slide, please, Stephen. Basically, kia ora whānau, e nā mihi nui ki a koutou katoa mo a koutou kōrero, o koutou mātauranga, o koutou whakaaro. This slide is just a shout out to everyone out there that would like to save this date. It's a real firecracker of a hui that we're going to have. Te Hiringa Mahara has partnered with, some of you will know it as themes, but the Mental Health Service Networking, Learning Networking company, or Ropu from Australia. So our Save the Date is for the 5th of November, Guy Fawkes Day, where we'll invite you all to register. Our actual conference will be run the partnership conference will be run every year. So we have an enduring name for that conference, and it's He Ara Orang, Hauora Hinengaro, He Ara Tūroa, Mental Health and Enduring Pathway. So each year, this partnership will host a conference in Aotearoa every year is the intention. But for this year, we're going to focus on crisis. So the kaupapa for this year on the 5th of November for that day is around Wainga Mōrearea, He Ara Oranga. So amidst crisis and distress, there are pathways to wellbeing. So you will get all this information emailed out to you as part of the recording. And in that, kua noho kia hau te honore, whakaiti ki te kati tātātou hui, mai tēnei uri o nai tūhoi, o te waimana kāku, te whārua, ko mauna pohatu taku mauna, ko tauranga te awa tapu, e rere ana wainanui woku, hipa atu ana I waku marae o te waimana. Nō reira ko Maraea Johns tu whenua tēnei, e kati nei, e kapi nei tā tātou hui I tēnei aiahi. Whakamaua te kōrero, whakamaua te wānanga, whakamaua te arangi e tui nei, whakamaua kia pikatua koe te koroa tēnei. Whakatīna te tumu o te māramatana kia tīna. Hui e, taiki e. Kia ora koutou.